So again, a warm welcome everyone to the Orlando GI Journal Club. It's October 5th, 2022, 7 a.m. Eastern Standard Time here in the United States. Our first study is going to be a randomized trial published in the New England Journal of Medicine this month, comparing aggressive and moderate fluid resuscitation in patients with acute pancreatitis. This study is important in our clinical practice because acute pancreatitis is a condition that our gastroenterologists see very frequently. And the current consensus stemming from initial observational studies is that hemoconcentration is associated with pancreatic necrosis. And therefore, aggressive hydration with IV fluids is common practice, especially in the initial stages of management of the patient with acute pancreatitis. But subsequent studies have indicated that administration of greater volume of fluid during the first 24 hours may not improve outcomes. And so these authors performed a randomized trial to investigate the safety and efficacy of aggressive fluid resuscitation compared with moderate fluid resuscitation in patients with acute pancreatitis. This was a randomized trial conducted in 4 countries and 18 centers. They enrolled patients with acute pancreatitis, but excluded patients with moderately severe or severe pancreatitis at baseline. So they excluded patients with shock, respiratory failure, and renal failure. In a 1-to-1 ratio, they randomized the patients to either aggressive fluid resuscitation or moderate fluid resuscitation. And the main difference is that for aggressive fluid resuscitation, patients were given bolus of 20 milliliter per kilogram of fluid. And then IV fluids, they used lactated ringers in the study, of 3 milliliter per kilogram per hour. For moderate fluid resuscitation, patients were given IV fluid, lactated ringers of 1.5 milliliter per kilogram per hour. And if patients were deemed to be hypovolemic on clinical examination, they were given a bolus of 10 milliliter per kilogram. At 3 hours, patients were checked for volume overload. And if that was the case, in both groups, IV fluids were decreased in rate or stopped according to their degree of fluid overload. And then they also implemented checkpoints at 12 hours, 24 hours, 48 hours, and 72 hours, where in both groups, they performed goal-directed therapy. The main difference is that for aggressive fluid resuscitation, in patients who were deemed to be hypovolemic, patients were given 20 milliliter per kilogram and then infusion of 3 milliliter per kilogram per hour again. And again, for moderate fluid resuscitation, in patients who were deemed to be hypovolemic, they were given a bolus of 10 milliliter per kilogram and then infusion of 1.5 milliliter per kilogram per hour. The management was essentially the same in patients after 12 hours who were deemed to be normovolemic or suspected of having fluid overload in both groups, where they were infused 1.5 milliliter per kilogram per hour for normovolemic patients, and then stopped or infusion rate was lowered in patients deemed to have fluid overload. Oral intake was started at 12 hours if abdominal pain score is less than 5 for each symptom on the PAN-PROMIS scale. The outcome measure, the primary outcome measure, was the development of moderately severe or severe acute pancreatitis per revised Atlanta classification during hospitalization. And the planned sample size was 744 patients, but they planned an interim analysis after 248 patients. And in this particular randomized trial, the randomized trial was halted early due to significant difference in safety outcomes without a significant difference in the incidence of moderately severe or severe pancreatitis. So these were the baseline characteristics. 122 patients were enrolled in the aggressive fluid resuscitation group, 127 patients in the moderate fluid resuscitation group. And as you would expect from a randomized trial, the baseline characteristics are and should be not significantly different between the two groups. If you look at patients with SIRS, it accounted for 28% in the aggressive group and 22.8% in a moderate group. And hypovolemia was encountered in just over 50% of the patient cohort in both groups. These are the outcome measures. So if you look at the primary outcome of the rate of moderately severe or severe pancreatitis, in the aggressive fluid group, it was 22% versus 17% in the moderate fluid resuscitation group. The relative risk was 1.28, and this relative risk was not statistically significant, with the 95% confidence interval spanning 1. It ranged from 0.7 to 2.1. When they looked at other clinical outcomes from the acute pancreatitis, they also found no significant difference in the rate of severe pancreatitis, the incidence of complications. Any complications occurred in 20% of aggressive group versus 16.5% in the moderate group. Again, relative risk was not statistically significant. When they looked at the rate of necrotizing pancreatitis, again, not significantly different between the two groups, and neither were the rates of infected necrotizing pancreatitis, occurring 4% in aggressive group and 2.4% in the moderate group. And they compared the rate of SIRS and persistent SIRS. Again, there was no significant difference between the aggressive and the moderate fluid resuscitation groups. When they looked at other outcomes, the only borderline significant result between the aggressive and the moderately aggressive resuscitation groups, with a median duration of hospital stay, 6 days in aggressive versus 5 days in the moderately aggressive group, with relative risk 1.31, with the confidence interval spanning from 1 to 1.7. But if you look at the other outcome measures, such as need for nutritional support, need for ICU care, organ failure, shock, mortality, there was no difference between the two groups. When they looked at the safety outcomes, comparing aggressive and moderate groups, this was the reason that the study was halted earlier. And they found that the rate of fluid overload was 20.5% in the aggressive group versus 6.3% in the moderate group. Now, the relative risk was 3.25, which means that if you're in the aggressive group, you were 3.25 times more likely to have fluid overload than compared to the moderate fluid group, with a confidence interval spanning from 1.5 to 6.9. When they looked at symptoms of fluid overload, such as dyspnea, this was also statistically significant. Signs of fluid overload, such as peripheral edema and pulmonary rales, were also statistically different between the two groups and more likely in the aggressive group. The main limitation of the study is that the study had to be terminated prematurely at first interim analysis because of the significant difference in the rate of fluid overload between the two groups. And therefore, the study is not powered to assess the efficacy of outcomes. This is also open label study, which means that the doctors and patients knew which group they were in, and they also excluded patients with moderately severe or severe disease at baseline. So the main take-home point is that in this randomized trial, early aggressive fluid resuscitation compared to moderate fluid resuscitation resulted in a high incidence of fluid overload without improvement in clinical outcomes in acute pancreatitis. Next is a study looking at the efficacy of fecal microbiota transplantation for patients with irritable bowel syndrome at 3 years after transplantation. This was published in Gastroenterology by L. Salhi et al. The study is important because intestinal bacterial composition is considered to play a pivotal role in IBS pathophysiology, and fecal microbiota transplant, FMT, might be a promising treatment for IBS. Currently, 7 randomized trials have been conducted looking at the role of FMT in IBS, and they have produced conflicting results. However, the long-term efficacy and adverse events of fecal microbiota transplant for IBS are unknown. So the aim of this study was to look at the 3-year follow-up of IBS patients who have undergone FMT in a previous clinical trial to assess long-term efficacy and adverse events. So what the authors did was they had conducted a trial looking at the role of FMT in IBS patients. So the initial randomized trial included patients over the age of 18 up to age 85 with a total score on the IBS severity scoring system of at least 175. And they were randomized into either placebo, 30 grams of transplant, frozen transplant, or 60 grams of frozen transplant. They obtained the transplant material from a single donor, and the material was instilled into the distal duodenum during an EGD. And then they asked the patients to provide fecal samples, and the patients underwent 5 different questionnaires, and they were completed at baseline, 2 years, and then 3 years post-FMT. So at the end of 3 years, 39 patients ended up in the 60-gram frozen transplant group, 37 patients in the 30-gram frozen transplant group, and 37 patients in the placebo group. These were the baseline characteristics. So a total of 125 patients were followed up to 3 years. And as you would expect, again, from a randomized trial, the baseline characteristics should be evenly spread between the 3 different groups. When they looked at the IBS types, they included 3 main types in this randomized trial: IBS-D, C, and M. The percentage of patients with severe IBS symptoms was 62% overall, 55% in placebo, 67% in the 30-gram group, and 62% in the 60-gram group. They then looked at the response rates. So the response rate was found to be significantly higher in the 30-gram and 60-gram FMD group in IBS patients compared with placebo at 2 and 3 year follow-up. And when the authors also looked at the rate of complete remission of symptoms, they also found significantly higher rate of complete remission in 30-gram and 60-gram FMT groups compared with placebo at 2 and 3 year follow-up. When they looked at symptom control and quality of life, they also found fewer IBS symptoms and greater quality of life in the 30-gram and 60-gram FMD groups compared with placebo at 2 and 3 year follow-up. When they looked at long-term adverse events, they found that there were no significant long-term adverse events in any of the groups. The main limitation of this study is the relatively small number of patients, 128 patients in total, being divided into 3 groups. And also the authors did not include the unsubtyped IBS subtype of in this study. The main take-home point is that FMT resulted in high response rates and long-standing beneficial effects in IBS patients at the end of 3 year follow-up. Our third study is looking at the efficacy of biological therapies and small molecules in moderate to severe ulcerative colitis. This was a network meta-analysis by Burr et al. Published in Gut this month. This study is important in our clinical practice because ulcerative colitis, as everybody is already aware, has a relapsing and remitting course with intermittent flares of disease activity. And over the last 20 years, novel drugs with more precise modes of action have been developed because flares were traditionally treated with steroids, but that's no longer the case. So in the last 20 years, we have started with anti-TNF-alpha medications that target cytokines such as infliximab, adalimumab, and golimumab. They also have biologics that target alpha and beta integrin, such as vedolizumab and etrolizumab. Then we have had the development of medications that target pro-inflammatory cytokines, such as ustekinumab, and then finally small molecules such as tofacitinib and ozanimod. So the aim of this meta-analysis was to evaluate the efficacy of all biologics and small molecules that have progressed to phase 3 trials to determine which medication is most effective in treating ulcerative colitis flares. So the authors included 28 clinical trials comprising over 12,000 patients, and they wanted to look at the rate of clinical remission, endoscopic improvement, clinical response, and safety of biologics and small molecules in ulcerative colitis. The first outcome they looked at was which medication was least likely to fail at achieving clinical remission. So if you look at these forest plots, this is for all patients. This forest plot is for patients who are anti-TNF alpha medication naive. And these patients included patients who were exposed to anti-TNF alpha medications before. So as you can see, the most effective in achieving clinical outcome, so the way the authors have worded this is least likely to fail to achieve clinical remission, was upadacitinib, 45 milligram dose, followed by infliximab at a dose of 5 milligram per kilogram and infliximab at 10 milligram per kilogram. When they looked at anti-TNF alpha naive patients, again, actually very exactly the same results. Upadacitinib was the most effective, followed by infliximab 5 milligram per kilogram, and then infliximab 10 milligram per kilogram. When they looked at patients who were exposed to anti-TNF alpha medications previously, upadacitinib was most effective, followed by ustekinumab, and then tofacitinib. This is too early for all these syllables, so bear with me if I'm getting some of the syllables, omitting some of the syllables. Okay, next. Now, next, they looked at the success of achieving endoscopic improvement. So again, the way they've looked at this is the failure to achieve endoscopic improvement. So again, this forest plot included all patients. It was a subgroup analysis of patients who were anti-TNF alpha naive, and this forest plot included only patients who had been exposed to anti-TNF alpha before. So in achieving endoscopic remission, infliximab at 10 milligram per kilogram was most effective, followed by upadacitinib and then infliximab. Again, for patients who were anti-TNF alpha naive, upadacitinib was most effective, and then infliximab at 10 milligram per kilogram, and then infliximab at 5 milligram per kilogram. For anti-TNF alpha exposed patients, the most effective was upadacitinib, followed by tofacitinib and ustekinumab. Next outcomes, they looked at clinical response. So again, the authors worded or analyzed as a failure to achieve clinical response. And so in the order of the most effective at achieving clinical response, when including all patients, were upadacitinib, followed by infliximab at 10 milligram per kilogram, and then ustekinumab at 6 milligram per kilogram. Then when they looked at patients who were naive to anti-TNF alpha, the order was similar. Upadacitinib, most effective, followed by ustekinumab, and then infliximab. When looking at anti-TNF alpha exposed patients, again, upadacitinib was most effective, followed by filgotinib, and then ustekinumab. Adverse events. When they looked at adverse events, they found that upadacitinib was more likely to lead to adverse events, but serious adverse events were no more frequent than placebo. Infections were most likely with tofacitinib compared with placebo, with relative risk of 1.41, and infections were least likely to occur with vedolizumab. The limitation of the study is that only 9 of the 20 plus studies, including this meta-analysis, were determined to be lowest risk for bias. And in the study, they looked at clinical trials looking at individual agents. And so there's no data or information available on what happens and what is the most effective treatment regime if combination of medications are being used to treat UC flares. So the take-home point is that in this network meta-analysis, upadacitinib, 45 milligram q daily, ranked first for clinical remission in all patients, patients naive to anti-TNF, and patients previously exposed to anti-TNF. Infliximab at dose of 10 milligram per kilogram ranked first for inducing endoscopic improvement, and most drugs were safe and well tolerated. This is our final study, published or just accepted in American Journal of Gastroenterology by Zalewski et al., looking at long-term outcomes of the 6-food elimination diet and food reintroduction in a large cohort of adults with eosinophilic esophagitis. EOE, or eosinophilic esophagitis, and it is an immune-mediated inflammatory condition with tissue eosinophilia and resultant esophageal dysfunction. 6-food elimination diet is the treatment approach that removes milk, wheat, soy, eggs, tree nuts / peanuts, and fish, shellfish from patients' diet with EOE. And large studies evaluating the outcomes and the efficacy of 6-food elimination diet, or SFED, in adult EOE patients is not well known. So these authors performed a retrospective study spanning a period of 15 years of 231 patients who were adults who were undergoing the 6-food elimination diet for at least 6 weeks at a single academic medical center in the United States. And they confirmed the response to this SFED with EGD and biopsies. And responders were defined as eosinophilic count per high power field of less than 15 on biopsies. And then as protocol, as standard of care in this well-known academic center for patients with EOE, they have a reintroduction protocol where food triggers are gradually introduced from the least likely to most likely causative item, and then EGD is repeated to assess for histological recurrence. So they had 213 patients who completed 6-food elimination diet, and then they found responders in 62% of patients. Full responders were accounted for 54%, and then partial responders 8%. Non-responders accounted for, of course, 38%. And when they repeated the 6-food elimination diet in this patient, actually 32 patients, when they repeated attempt, when they repeated attempt with the 6-food elimination diet, they found 27% full responders, 18% partial responders, and 55% non-responders. So the overall non-responder rate ended up being 33%. So when they looked at the endoscopic and histological outcomes of responders and non-responders, for responders, the pre-6-food elimination diet and post-6-food elimination diet was significantly different in the total EREF score, and also the peak eosinophilic count per high power field on biopsies. When they looked at non-responders, there was no significant difference pre and post elimination diet in the total EREF score and the peak eosinophilic count per high power field on biopsies. The main limitation of this study is that this is a retrospective study with, of course, their inherent biases. This was also performed in a single tertiary academic center, and therefore the results of this study has a limited generalizability. As everyone's already aware, 6-food elimination diet is notoriously difficult to maintain in order to make sure that patients are well supported requires huge amounts of resources, including nutrition and dietary support, frequent follow-up, needs huge amount of ancillary support, which is likely not going to be universally available around the world and including the United States. So the main take-home point of the study is that adult patients with EOE, overall 6-food elimination diet histological response rate was 54%, which increased to 58% with one additional round of diet therapy. Most patients who completed food reintroduction had a single food trigger identified, and dietary elimination with specific food trigger identification is a feasible alternative to medical therapy. To recap the Journal Club for today, in the randomized trial comparing aggressive and moderate fluid resuscitation in patients with acute pancreatitis, early aggressive fluid resuscitation and compared to moderate fluid resuscitation resulted in high incidence of fluid overload without improvement in clinical outcomes. Fecal microbiota transplant resulted in high response rates and long-standing beneficial effects in IBS patients. In a network meta-analysis, upadacitinib at 45 milligram per daily ranked first for clinical remission in all patients naive to anti-TNF-alpha and patients previously exposed to anti-TNF-alpha agents. Infliximab at 10 milligram per kilogram ranked first for endoscopic improvement, and most drugs were safe and well tolerated. Lastly, in adult patients with eosinophilic esophagitis, overall histological response rate to 6-food elimination diet was 54%, which increased to 58% with an additional round of dietary therapy. Most patients who completed food reintroduction had a single food trigger identified, and dietary elimination with specific food trigger identification is a feasible alternative to medical therapy. So thank you so much for joining us this morning. Our next monthly Journal Club, it will be on November 2nd, which is the first Wednesday of November. I hope everyone has a wonderful month and staying safe. And we look forward to seeing you next month. Thank you so much.